Hi everyone, my name is Vincenzo Berghella. I'm maternal-fetal medicine here at Jefferson and editor-in-chief at AJOG MFM. Welcome again to another editions of AJOG MFM Update, together with my good friend Mo Mhatre. Hi Mo.
Hi everyone, nice to see all of you. I am Mo Mhatre. I'm a maternal fetal medicine specialist at Tufts Medical Center in Boston and the director of the MFM Fellowship here at Tufts. Really excited to have all of you join us today. I'm going to let Dr. Berghella give a quick update about a new edition we have coming through before we launch into our series for this month.
Yeah, we'll go over, as usual, the 4 articles of the month for September, but also want to tell you that later on, in a couple of weeks, we'll do a special AJOG MFM update on a special collection edition on cesarean delivery, which is now live. You can go and check it on ajogmfm.org. Again, that's ajogmfm.org. There's now an editorial and a bunch of articles, and we'll go over that on September 22nd. With that brief introduction, Mo, you can take it away.
Yeah, so for those of you who are unfamiliar with our format, we go through the month's issue, through all of the amazing work, and we try to select 4 articles that we want to highlight for you today. These are going to be studies that we think have a robust study design and are also very helpful for counseling and management of patients who are on the labor floor or in your office. And we hope that these studies are helpful not only to our MFM colleagues, but to all of the providers who care for patients who are pregnant, such as our OBGYN generalists, family medicine doctors, nurse practitioners, PAs, midwives. And we are going to use visual abstracts that are either done by the authors or created by me. And you can feel free to look at the articles in detail on ajogmfm.org. And take it away, Dr. Berghella.
So thanks to this group at WashU, and leading them for doing this systematic review meta-analysis on a common topic, if to give a diuretic, in particular a loop diuretic, like Lasix, for example, to people postpartum. And thank you for them to do the infographics. Basically, they did find quite a few randomized studies, 9 using furosemide again. Torsemide is very close cousin, newer version of furosemide. And I guess, unfortunately, they didn't find much evidence of benefit for readmissions. They did find a lower additional antihypertensive requirement. But overall, mothers did about the same, except for needing less antihypertensive. Obviously, if you are on a antihypertensive like Lasix, you're not going to need another one. So they concluded insufficient evidence to support prophylactic postpartum loop diuretic in patients at risk for readmissions for hypertension. And included in these trials were mostly patients with preeclampsia with severe feature, chronic hypertension, etc. So I'm actually hoping that this eventually becomes a truth. Penn did a nice article on this, which was positive a while ago, which is included in this meta-analysis. But I guess this author didn't think that the evidence is strong enough yet, to see really maternal benefits. Obviously, you lower blood pressure, you need less antihypertensive requirement, but we're not there yet to say to all these high-risk patients, we start you on furosemide, no matter what, just based on preventive principles. But a very interesting topic, and I think, and a wonderful article.
Wonderful. Our next study that we're going to present, we have 2 studies about cesarean section and wound infections. The first one is going to be a meta-analysis of some randomized trials by Dr. Berghella and his colleagues. This is looking at early wound dressing removal after cesarean delivery. And we know that 1 in every 3 women have a C-section, and certainly with the high rates of C-section, there's the risk of wound complications. And we know that there's evidence to support, vaginal prep, closing the sub-Q at over 2 centimeters, Then we have, some standardized methods to reduce wound infection. The question is if the timing of when you remove the dressing, if that can also impact the rates of wound infection. And there's, some controversy between how long to keep it on. Should we keep it less than 24 hours or more than 48 hours? And so that's what this study was trying to evaluate. It performed a systematic review of 4 databases and was able to identify 4 RCTs to include in a meta-analysis. And they compared less than 24-hour removal versus waiting till at least 48 hours. And their outcomes found that the early removal did not have any difference in the rates of wound infection, disruption of the wound, development of a seroma or hematoma. There was one study that looked at patient satisfaction that did show improvement in patient satisfaction with the early removal. And so this suggests that this is, a possible way to go for our patients on the postpartum floor. Certainly is supported by a Cochrane review from the general surgery literature to support early wound dressing removal. So, I think this is, again, supporting that movement, and we'll see if we start moving our patient care that way too.
Thank you, Mo. I think the earliest removal in those randomized studies was 6 hours. So, you could remove it pretty early if you wanted to. This is a comparative systematic review on guidelines on cerclage. Cerclage is really a topic I've been interested in for a long time. And so I was very happy when these investigators, mostly from Israel, but also from the US, kind of looked at many guidelines. They looked at FIGO guidelines, ISO guidelines, AJOG guidelines, RCOG guidelines, SMFM guidelines on cerclage. And basically, they found some agreements, like doing a history-indicated cerclage, people with multiple early second trimester losses, like 3 or more. They found that ultrasound-indicated cerclage will be indicated even in people without a preterm birth if the cervix was very short, 10 millimeters or less. And they also agreed that abdominal cerclage, the 2 more common indications, would be for a failed prior transvaginal cerclage, placed at 12 weeks and you deliver early anyway, or if there is insufficient cervical tissue, even if I would say the evidence is not much there. But there was some agreement, but there was a lot of disagreement on other things. For example, as you know, AJOG says you could do maybe a history-indicated cerclage just on 1 second trimester losses, while the other ones say 3. On twins, there is a lot of variability, probably because there is a lot less data. And also, progesterone versus cerclage in specific scenarios, should use the 2 together, 1 versus the other, etc. And that's, I think, also based on the fact that, the data there, it's not extensive yet. So I think interesting review. We practice one way, but, there's certainly variation. And I think my take is compared to 20, 30 years ago, we actually practice more similarly around the world. And as you can see, there are some similarities, even in a complex, controversial topic as cerclage, but we have a lot to go. And I think hopefully as new level 1 data comes out, the guidelines will continue to say the same thing. Otherwise, without much guidance, then maybe, individual preferences, in the guideline committee, it may take the lead, so to speak. But interesting article for sure.
All right, and our last paper is going to be another systematic review and meta-analysis, this time on subcutaneous tissue closure and post-op wound complications and cesarean delivery. As we talked about, over 2 centimeters is the evidence supports closing the sub-Q. But what about for everyone, regardless of the depth of the sub-Q tissue layer? So this paper was looking at a meta-analysis of RCTs. I think they found 9 or 10 RCTs to look at universal closure for all pregnant patients, specifically excluding trials that only focused on obese patients or only focused on sub-Q tissue closure over 2 centimeters. They looked, again, similar outcomes as our other meta-analysis, looking at individual components of wound complications, as well as a composite outcome. Ultimately, what they found is that universal subcutaneous closure does not significantly change the rates of wound complications. And, you know, that seems to be a challenge for us to use that consistently for all patients. They did try to look at cosmesis and post-op pain control as well, but there was just not enough data for that. And the studies didn't really, they couldn't really evaluate like the type of suture or the technique or anything to evaluate that further. But at least it seems that in terms of a depth perspective, closing the tissue layer when it's less than 2 centimeters thick does not appear to make a difference for wound complications.
Yeah, I was a little bit surprised. I've been closing the sub-Q at C-section if it's 2 or more for over 10 years. I think there's been good data, and I thought, why shouldn't it work at less than 2? But I guess they didn't find the thing. So I'm continuing to do what I do, just 2 or more centimeters, and I'll close the sub-Q. Well, thanks, Mo, for a great review. We'll do the cesarean delivery special issue highlights again on September 22nd. So I hope to see you there on social media. And then again with Mo. And with Mo again, we'll do the October 2025 highlight, hopefully early in October again. Thanks for being with us, and have a great day, and go AJOG MFM.
Bye, everyone. Thank you.